Good morning, my name's Yan Leung. It's a pleasure for me to be here to present our collaborative work looking at preoperative predictors of outcome following male Sling implant for post-prostatectomy incontinence. We have no disclosures. So following the hold in placing any further male slings in the UK, we wanted to review our own data. So firstly, looking at our functional outcomes, and secondly, reviewing our data to see if we could identify any preoperative parameters that might help us aid patient selection. So we did this by collecting our data prospectively across the two tertiary centres, so that's University College London Hospital and St George's Hospital in London. We did this between 2012 and 2018. We defined dry or a successful operation or defined them by 0 pads a day or 1 safety pad a day, and those being wet as using more than 1 pad a day postoperatively. The preoperative parameters that we looked at included whether the patient underwent previous radiotherapy, the severity of the urinary incontinence, and urodynamics, including looking at if they had detrusor overactivity, the bladder capacity, and the retrograde leak point pressure. So looking at our cohort, we had 100 patients who had the male sling implanted. The average age was 67, and the mean follow-up time was 3¼ years. Looking at our functional outcomes, we can see of the 100 men, 73% of them were dry post-operatively. So that was using 0 or 1 pad a day. And actually 46% of this 100 patients were using no pads a day after the operation. 27% of our patients continued to be wet. Looking at our preoperative parameters, the ones which are statistically significant in our cohort were the number of preoperative pad usage, proven detrusor overactivity on urodynamics, and their bladder capacity. And we'll just look at these in a little bit more detail. So looking firstly at the preoperative number of pads, we can see here in our cohort that those who are using more pads before the operation were less likely to have a successful operation. So we might be able to suggest in our cohort that the severity of the urinary incontinence might be linked to poorer outcomes with the male sling. Looking at detrusor overactivity, of those who had proven detrusor overactivity on the urodynamics preoperatively, they were likely to have worse outcomes postoperatively. And similarly, we might be able to suggest in our cohort that detrusor overactivity preoperatively is linked to poorer outcomes. And lastly, we can see on this weighted histogram, so we can see the bladder capacity along the side and those who are dry postoperatively at the top and wet postoperatively on the bottom. We can see those who are dry postoperatively had a higher bladder capacity preoperatively. And so you might be able to suggest that those who had a reduced bladder capacity preoperatively were linked to worse outcomes. So in conclusion, in our cohort, we had a 73% success rate. The poor predictors of outcome we can see here, and we would therefore recommend moving forwards that all patients undergo video urodynamics preoperatively, and this might help us aid patient counselling in terms of their operation, and also we should look forward to the results of the Masters trial. Thank you very much. Any questions?
Thank you very much for these clear statements. I have two questions. One, did I miss irradiation? Was that the contraindication? And the second question would be, how did you technically make the retrograde leak point pressure in an awake patient?
Yeah, so I'll do my best to answer your question. So the first question, we did look at previous radiotherapy. In our cohort, it wasn't statistically significant, so I didn't have time to include it all. But actually, we believe it might be a bit of patient selection bias. So it is potentially understood or recognized that previous radiotherapy might be linked to worse outcomes. So in our counselling, when we talk to our patients, if they opt not to have the male sling, that could be why our statistics were not statistically significant. Okay. And response to your second question, so retrograde leak point pressure, my consultants do it, but they do manage to do it in patients who are awake. So they use a pediatric blood pressure cuff, and they put it just distal to the external sphincter. Obviously, they place the catheter in, and actually patients find it a bit uncomfortable, but they do manage the procedure quite well. They tolerate it quite well, and actually it's quite short, so they would tolerate it.
But the question goes more to the direction that you have to rule out the pelvic floor somehow. Because if the patient contracts, you will have, and he will be able to contract, you will have a retrograde leak point pressure of 100 maybe. And so you simply tell them to relax, or how do you do that?
That is my understanding, but I don't perform the procedure myself, so I'd have to clarify that.
Okay, thank you.
Thank you.
Very well described, yeah. You do it under video control, so you put a small 6 feeding tube like she described, you put the pediatric cuff, and you slowly fill the bladder up, fill the tube up, and you do the video at the same time. And as it goes up, you can see as it goes above, the pressure starts to rise, and if it overcomes the pressure offered by the resistance, you can see the pressure fall, and you can see the dye going into the bladder. That's how you do it. They have described it well.
No,
Is it validated?
Yes, more one question, please.
Described it, yes.
What's the results of retrograde per pressure? What help you in decision? What is the results?
Oh, so ours wasn't statistically significant. We only had a small number of patients in our cohort who actually had the retrograde leak point pressure conducted, but it wasn't statistically significant in our cohort.
Thank you. I'm afraid there is something wrong with your table in the abstract.
Oh.
Yeah, so
okay.
look at it
I will
again.
look at it and submit the proper version. Thank you.
Thanks very much.